Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live. Actually, a very, very special live edition. We got off to a little bit of a slow start here, so I appreciate all of you that are on the live chat waiting for us. Had some technical difficulties, but we got them all worked out. I am James Fabin. I'm a kidney warrior. I'm sitting here, learning as much as I can, working with my doctors, eating as healthy as I can, not as healthy as I should. I got to cut back on those carbs. But the more you know, the better you can be at being proactive at your health. And the best source for learning is from a kidney professional. And we've got one that you all love here with us tonight. My co-host is the author of the book, Learn the Facts About Kidney Disease. And this was the book that I wish when I was diagnosed that my doctor handed me and said, James, I know it sounds scary. Stay away from the internet until after you read this book. Oh, things would have been so much better for me when I was diagnosed if that would have happened. But this book makes understanding kidney disease much easier. You know what matters, what's important, and what you can do to be proactive in your care. Now, the author of that is Dr. Steve Rosansky. He is here tonight. We are doing a special Q&A session. So start typing your questions in the chat. We've already got a lot of people in there saying hi and entering questions in there. And we're going to go through those and try to answer as many of those as we can here. Pixie says, is this live tonight or today? Yes, it is, Pixie. It is 7:07 p.m. Eastern time here in Detroit, Michigan, and we're coming at you live. Let me bring on my co-host, Dr. Steve Rosansky. Hey, Doc.
Hey, James. Well, at least we got a picture. This picture looks a little fuzzy on my end, but anyway, it looks okay. I mean, we had a little trouble getting started tonight.
Yeah. Hey, we got you here. I'm happy to have you here.
Hopefully, we won't have any more of these technical difficulties. But yeah, I just figured, James, I've been very busy traveling and didn't really have time to prepare. I like to prepare a topic for your viewers, and I just figured we'd give it a shot to just answer questions, because most of the time we can't get to all the questions. And I'm sure a lot of folks have questions that they like to find out about their kidney problem. So we'll try it tonight. Let's see what happens. And for those folks who don't know who I am, I'm a retired nephrologist with over 40 years of experience treating patients with kidney disease. I'm also what they call an academic nephrologist, in that I've done a good bit of research, published over 100, have over 100 publications in my name. And I've written the book because one of the reasons is a lot of folks were not getting the correct information about what their kidney number means, what you can do about your kidney problem, and what really is important if you happen to have an abnormal eGFR, kidney number, and especially if you have protein in the urine. And also my research on when to start dialysis has been widely applauded. One of my papers about the issue of when to start dialysis was voted the #1 game changer in my field. So I think I have a lot to say to you folks. And the reason why I wrote the book is that doctors were still starting patients way too early, even though the research is out there showing that that is not good for your long-term survival. So that's a little bit in the way of background. And I don't know how you want to handle this, James. You want to give me some of your questions?
I'll give you some, and you can see them on your side and pick some. And this is fantastic. Lots of time to answer questions. And we're going to start off with one. Monita Johnson asks, and this is, I'm going to guess she's very new to this. She asks, what does it mean when a doctor tells you Your eGFR is 47.
Excellent question. Thank you for that question. That means close to nothing, but we'll try to expand on that. 47 is not a real number. Your eGFR, even if we had the E, is for estimated. GFR is glomerular filtration rate. In other words, how fast the flow is going through your kidneys, through the units of the kidney, which are called the glomeruli. Your kidneys have a couple million of these glomeruli, and that's what is the business end of your kidney. So you got an E, an estimate of your glomerular filtration rate. And if you repeat that estimate, you're going to get lots of variation. So the 47, I would say anywhere easily plus or minus 10%, let's say plus or minus 5, let's say it was 50, it could be 45 or 55. I would say that would be the same number roughly. Now, we used to talk about the eGFR number, again, it's an estimate, above 60. And a lot of people had these numbers above 60. And for most labs, they're just going to report over 60 because those numbers become much, much less accurate the higher the number. So that's one issue. Another issue about eGFR, the estimated number, is that depending on your age, Monita, if you happen to be my age, and which is 76, with an eGFR of 47, that could be normal for me. Now, if you are much younger, that is an eGFR that would be technically in the range of having chronic kidney disease. But there's no sense in talking about anybody's eGFR without another extremely important piece of data. And what is that, James?
Protein in the urine?
Absolutely, absolutely. And it's just so sad that there are so many healthcare delivery organizations that have not learned this lesson. That urine protein is probably, for most of you, a more important parameter than that thing that people are panicking about. What's your kidney number? And you can, okay, and let me give you an example. Let's just say that your kidney number was 70. Are you in the clear, James? If someone says, oh, my kidney number was 70, so it's above 60, so what do you think? Am I good?
Well, that part's nice, but are you leaking protein? If you're leaking a lot of protein, there's a problem.
Okay, by definition, and this is just by definition, and we'll get into what it really means for each of you patients. If you are 70, 80, over 60, but you have protein in the urine, you have CKD. And what is protein in the urine? The way your urine protein should be measured, and this is going to become a standard for laboratories, hopefully across the world, is how? How do we get that urine protein an accurate measure, aside from a dipstick in the urine, which is good. I'm not against dipsticks. Urine dipsticks is a good screen. But the other test that I'm thinking of is a much more reliable and much more accurate expression of how much protein in the urine. What is
Is that
that?
the urinalysis?
It's a lab test. It's a lab test, James.
Oh,
It's the urine watt to watt. It's a ratio.
it's protein or darn it. I cannot remember. It starts with C, doesn't it?
It's the albumin.
Albumin.
Okay. If you go to your doctor, they're going to get a level of the albumin, which is the major protein in the blood. But the major protein you're spilling in the urine is albumin. And when there's albumin in the urine, the fancy term for that is albuminuria, albumin in the urine. So you should get every kidney patient, and if your doc's not doing it, you tell them, I heard this discussion by this doctor who's written a book for patients, and he said everybody who's got a kidney issue that's being evaluated must have a urine test. It's the urine albumin over the urine creatinine ratio. So the lab will measure the albumin and a little bit of urine. You just need a few cc's. You don't need a lot. You don't need to fill up a cup.
Oh, Doc got a glitch right there, and Sheila got it right. Don got it right. Let's see if Doc comes back. I hope he does. Let me check.
Boy.
All right, you froze for a moment there, Doc, but you're back.
Oh boy. Okay. I hope we're not going to have more of this. Okay. It's the albumin to creatinine ratio. And for people in this country, a value over 3 is considered abnormal. Outside of the U.S., you use the millimoles, a value over 30 in the U.S., a value over 3 if they're using the millimoles. It's a different kind of measurement. But yeah, and so you have the age factor, you have, and is one other thing about the 47. If that person, I forgot the name, had one value of 47, is that considered CKD, James? That one value?
Not one value. You need multiple values over at least 3 months.
Good. Perfect. Okay, so there's an international group of kidney doctors, which I participated with them in figuring out the best treatment for you folks with kidney disease. It's called KDIGO. You can look them up, KDIGO. They've got an enormous amount of information for you folks with kidney disease. We make the definition. We've all agreed it's got to be at least 2 values less than 60 with at least 3 months between. That's how you say, okay, I've got CKD. So that was the first question.
Yeah, there you go.
But it's a good one. It's an important question.
Oh, yeah, a very good. And that's one of the things when you first get diagnosed, you are so focused on the eGFR, and you don't understand because they don't explain. It's going to fluctuate. We need to look at the trends. And mine, it fluctuates, goes up and down about 5 points. It's stable. If it drops somewhere in that trend, I don't worry, because the next time it's probably going to be up a little bit. It's staying right in that trend where I'm at. But the internet doesn't talk about the importance of protein, which is, that's the big indicator.
I'm going to go ahead tonight and pick them out since I don't have any books in front of me. Dawn said ACR. ACR. Dawn, I'm going to ask my buddy right here. What is ACR, James?
That was the albumin creatinine ratio.
Yes, absolutely. Albumin creatinine ratio. Ask your doctor, what's my ACR? More important than your eGFR. I'm glad we started out on a high note. That's really important.
Okay, and Manita was 54 years old, so she's slightly, just barely older than me. And you call us young folks, so I like that.
Okay. I'm going to just read from the, wow, they're coming in. Should I read from the top or the bottom?
Hey, whatever. Just say something and I'll find it and bring it up.
Let me start from the bottom because I get, which one's coming in first, the top or the bottom?
The top is the oldest.
Top is the oldest. Okay. Okay. All right. Here's somebody. Okay. This is Resi. I was advised to have dialysis last April, and it's now September, doing the best that I can, and so inspired by you, James. Okay. Well,
thank you.
This is Resi. Okay. This is Resi, and for all of you folks that have what they call stage 5, and again, these are arbitrary stages. Don't get excited. Don't get panicky when your number falls into that stage 5. It's less than 15 on the eGFR, on your estimated kidney number. And frankly, my research showed that many people who are starting dialysis even above 15, and at levels of 10 to 15. And the research from my research and a lot of other people, this is looking at tens of thousands of patients, looking at the relationship between what your kidney number is when you start and your survival. And it seems that starting around 5 or less is the sweet spot if you can manage all the other medical problems that you might have that would go along with having advanced CKD. But my general advice to people is if your doctor should have a specific reason for starting you. You can't control my fluids with diuretics. You can't control my potassium. Or you've got a terrible GI problem where I just have no appetite, and see whether dialysis would help. There's got to be a really good reason to go on dialysis and not just your number. And certainly the numbers over 10, and there's a lot of research that's considered early start, that may be harmful. That was my game changer publication. Starting over 10 may be harmful. That's the message of my paper. Now, Imelda, my husband's stage 4, his lab shows potassium is borderline. His creatinine is, I guess, is 2.6 roughly. Please help us get the state. Okay. So, Imelda, again, I don't know anything more about your husband's situation. And the fact that his potassium is borderline doesn't mean anything to me. The main thing is, if he is a patient with protein in the urine, he should be on at least 2 classes of drugs. The first class of drug, and these drugs will, and your question here is, get back to stage 3. Don't worry about getting back to stage 3. You want to slow the decline. Forget about stage 3, stage 4. Those are arbitrary. You want to slow the decline. And there are classes of drugs that definitely will slow the decline, especially if they are a patient with protein in the urine. And what are those 3? What is the first class of drugs that we use historically? James knows them.
ACE or ARBs, or ACE and ARBs, one or the other.
Yeah, and I would say because they're equally priced, and there may be more side effects with the ACEs end in pril, captopril, enalapril, benazepril. The ARBs end in tan, losartan, telmisartan. I would take one of the tan drugs, less side effects, and you need to be on the maximum dose, no low dose. If you've got protein in the urine and you want to do what you can to slow your kidney down, the decline, your doctor should be on the maximum dose. One of those types of drug, either ACE or an ARB. The second kind of drug that you should be on in today's world, if you got protein in the urine and you want to slow your decline, is what, James?
SGLT2?
Yes, SGLT2s. There's about 5 different types of SGLT2s, and each of these drugs, whether you should be on either an ACE or an ARB and an SGLT2, maximum dose, and that can decrease the protein in the urine by a significant amount, and with that you will get a slowing of your decline. And the last class of drugs is something that you're on, I think, James, is the aldosterone antagonists like eplerenone, spironolactone. Okay,
that one I'm on. Yep.
And go back the discussion about protein in the urine. It was a very popular Dadvice, one of the most popular. Go back over that. A lot of you have already listened to it, but that is extremely important. And I'm not going to spend the whole time on that tonight.
Yep. Here's what I'd like you to do, Doc. It's Helen. She's 75 with an eGFR of 59, and her doctor told her she has stage 3 kidney disease. She's not diabetic and she has no high blood pressure. Can you talk a little bit about that? Because I'm sure she's pretty worried.
How old did you say she is?
75 at
Yeah. So
59.
again, you may well have an eGFR that, especially if you have no significant amount of protein in the urine, that estimated number of your kidney number may be normal for your age. Your kidney function will decline steadily by about a point, 3/4 of a point every year after the age of 40. That's just a normal thing. So I think with no other, what they call comorbidities, high blood pressure, diabetes, and no protein in the urine, not to worry.
Yeah, very good. Thank you.
Here's a great one, MY. What percentage of folks that are diagnosed with CKD end up on dialysis? Great, great question. What would you think? What would you think, James?
I was shocked to learn it was not that many.
It is very low. Let me give you an example by way of example. If you are somebody that's got let's say a 30 to 60 stage 3 in that range today, let's say there's 100 of you, less than 5% are ever going to have to worry about dialysis. But what is the thing that your patients with stage 3 and even stage 4 need to be more concerned about than going on a kidney machine or needing a kidney transplant? What is the thing that they should be very proactive about, that people with abnormal kidney numbers, as they get lower, it gets more severe, and with higher amounts of protein, what is the thing that they need to try to protect themselves against?
Is this the word I hate saying?
Yes, yes.
And you say it so well. It's hardening of the arteries. It's heart disease.
Right.
I'm going to shorten it.
Right. You folks, again, 95 out of 100 have to worry much more about getting a heart attack, getting a stroke, getting heart failure, than you have to worry about going on a kidney machine. And you need to take care of all of the risk factors, which include your exercise, which is crucial. No smoking, absolutely not. That will you stop smoking and you can improve your kidneys as well as everything else, your lung function and your heart function. You want to get your lipids controlled, get your bad cholesterol, the LDL, in the 50 range is what I like to shoot for. You want to get your blood pressure top number 130 or less, to get less trouble with your heart and so forth. And even if you can shoot for 120, that would be great. And this is what you really should be focusing on. Not, oh, I got a number that's 60 or 50 or 45 or even 35 and I'm going to be on dialysis. No. If you've got a lot of protein, you do need to focus on the protein in the urine. And there's at least 3 different types of drugs that may help with that. And by the way, the weight loss drug, the GLP-1, the jury's out on that. So there may be 4 drugs. The weight loss drugs definitely help with weight loss, and they help with the issues related to obesity, which are hypertension, diabetes, and it is probably the case that you will lose your kidney function faster if you are obese. So if you can get rid of some of that weight, it's probably going to help. And there may actually be a definitive study coming out on those weight loss drugs to help protect you from progressive kidney disease. Hydralazine, Olivia is at. So I'm going to do, in the next couple of months, I'm going to do a high blood pressure medicine talk, because a lot of people are very confused about all the various blood pressure meds, which meds are good, which meds are bad. So I'm going to talk about that. The hydralazine is an old drug. It is safe. It's generally not used a lot because you've got to take it with other drugs. You got to take it with a diuretic and something called an alpha blocker or beta blocker. So it's not so easy to use, but it works, and it's safe. But it's not a first line drug for kidney patients. And so this is sexy. Somebody talking about how do you get protein? How do you get protein out of your urine? Okay. So I'm sure. Okay, let me move on before we.
Yeah,
You
mentioned that with the ACEs, the ARBs. Yeah.
Okay, Henry Zhao says I am on a low protein diet as my GFR dropped to 26. What supplement of essential amino acids can I take to help nutrition?
And there are multiple questions about supplements, so this is great.
Henry, I love this question. And Henry, you've got a GFR. Okay, Henry, your GFR, again, is not the key issue. The key issue is what is the protein in the urine? What type of kidney disease do you have? Have you had a kidney biopsy? And so forth. Because there's a lot of other things that I would need to know. But in general, if you're diabetic, you should not be on a low protein diet. You should be on at least 60 to 80 grams of protein, because otherwise you have a danger of hypoglycemia, which is deadly, and malnutrition, which is also deadly. Too many people think that low protein diet is the thing to do if you've got CKD. That is not the recommendation of the international kidney experts like myself who've discussed this issue. And what we say is, look, in the US, I'm not sure where you are calling from or writing from, but in the US, we are in the 100 to 120 gram protein diet range. If you can get yourself down to 60 to 80 grams, that is a relatively low protein diet, and that would be fine. Getting yourself down to 20 to 40 grams, which is the very low protein diet, I highly, highly discourage. It is dangerous. There's virtually no data that shows it really will help you. And that's the situation where you may need to take the keto acid supplements. But I would say that would be my last thing that I would recommend for a patient who has tried everything else. They've done everything to decrease the protein in the urine, control their blood pressure, control all the other risk factors. If everything else is being done and you want to give it a shot, I would say that's the only time. But I would definitely not do it for the vast majority of you folks. It's not possible. Okay, so is it possible for one kidney to be leaking protein and the other not? No. So basically, the fact that there's protein in the urine means that there's what you call a systemic problem affecting the kidney. Whether it's diabetes or whether it's some other kind of disorder, it's going to affect both kidneys. So yeah, what happens to one happens to the other. And Dawn says, I'm glad your nephrologist is focusing on your high urine protein.
Dawn is a regular. I think I see her every time we have a broadcast. She's always very supportive, asks great questions.
I'm looking at Michelle's question. 46-year-old, creatinine 2.7, GFR of 21. I'm not sure what Tennofed is. Can you look that up real fast for me, James?
Yeah.
Okay. Yeah, I mean, 2.7, and that GFR sounds low for a creatinine of 2.7. But again, Michelle, the first drug for anyone with kidney disease should be an ACE or an ARB, a first blood pressure drug. What does Tennofed come up with?
All right. It's used for treatment of chest pain, angina, arrhythmias.
What's the generic name? What's in it?
Let's see. one second, trying to see if I can find the generic name.
All right, let me see.
Boy, they've done a good job at marketing that brand.
Yeah, well,
Nifedipine,
basically, huh?
Nifedipine.
Oh, okay. All right. All right. Now, and I'm going to discuss Tennofed. I'm looking it up. Tennofed. It's a common. First of all, I think it's useless. I would get off it. I see no need for combined drugs. Tennofed is a capsule administered. Let's see what's in it. It doesn't even tell you what the heck's in it. Do
Yeah,
you
I'm
get the
having
actual?
trouble finding it.
It's something in New Delhi. I guess it's but yeah, I would say this. Uh, you need to be, again, on an ACE or an ARB. You need to know how much protein in the urine. These other drugs, the Clenofed, whether it's nifedipine, which is a calcium channel blocker, and again, I'm going to discuss all these on my talk on high blood pressure. I would say no. I would say that doesn't make any sense. You should be on an ACE or an ARB, and if you have protein in the urine, you should be on an SGLT2. So I'm not sure why that you're being prescribed this drug. Uh, uh, yeah, so basically, Shane is asking about the ratio. The reason for the ratio is that you will have people drinking different amounts of water, putting out different amounts of urine. And when you get the creatinine value, in addition to the protein value, you can adjust for the varying intakes of water, whether you're on a diuretic. So it will adjust for it. Just looking at a dipstick protein or just the protein itself doesn't adjust for it. That's why you need the ratio of the urine protein divided by the urine albumin divided by urine creatinine. Now, somebody's talking about measurement of the blockage. I just blockage. Okay, so yeah, I mean blockage of the arteries to the kidneys. That's called renal artery stenosis. It's not rare, but it's not real common. It's what they call a secondary cause of high blood pressure, when one of the arteries to your kidneys is narrowed. Much more common in older folks. And you know, there we used to be very aggressive about trying to open up the arteries and bypass the arteries, but the research has not been strong to show benefit. So basically, it's controlling blood pressure is really the key thing. You want to get your blood pressure below 130, and if you can, to 120.
Now, Doc, we
Uh,
have one person who's asked multiple times the same question. Um, he's got a lot of information about the BUN 27, phosphorus 6. He's asking your thoughts on supplements. Can you
yeah.
talk about,
Oh,
because that's always a big thing. People, I get these
yeah.
emails every day. What supplement should I take?
Okay. Well, this is not just my opinion. It's the opinion of the National Kidney Foundation in the United States, and it's the opinion of other bodies that are impartial and have scientists on their boards. And basically, we recommend against supplements. There's no proof that these work, and they may well be harmful. Some supplements have been shown to be harmful. Okay. There are some herbal medicines that have been shown to actually cause kidney failure. You've got to be very careful because supplements are not regulated by the FDA. There could be potassium in it. There could be other things that could be dangerous for you. None of these supplements are proven to benefit you. I talked to you about the classes of drugs that we mentioned earlier, whether it's the ACEs, the ARBs, the SGLT2s, the aldosterone antagonists. These are massively large studies, numerous studies that are showing a benefit. You want to use what benefits you and not waste your money on what we call woo woo, on things that have no scientific basis. So save your money and stay away from the supplements. MY, what's more detrimental, high blood pressure or high blood sugar? I would have to. That's a good question, but my personal opinion is probably blood pressure, and I'll tell you why. If you are a early diabetic, and there are studies to support this, and you get your sugar under tight control, your A1C between 6.5 and 7, you could probably slow down the damage that diabetes causes in your eyes. People with diabetes lose vision. When your nerve, they get peripheral neuropathy, they get nerve pain, which can be very severe. So, yeah, you can probably, and your kidney problem. These are called small vessel problems. If you treat a diabetic who's young and controlling your sugar tightly, you can help. No matter what your age, if you control your blood pressure, you're going to help your kidneys. If you're an older person with diabetes, we recommend an A1C around 8 because there's no evidence that tighter control will help you with your kidney problem, your heart problem, your nerve problem, your eye problem. No evidence. And there's evidence that you can get severe low blood sugar, which could kill. So I would say, in general, blood pressure for most people, more so. It's an important thing for everyone. Would be blood pressure and blood sugar for new diabetics. Um, and okay, there's another drug in here that's something you see. There's something called Corendia. I don't know. You know what that is?
Nope.
Okay, well, uh, I'll look it up real quick. I have not heard
Yeah,
of
while
it.
you're looking that up, I want to add my input on supplements. If
Go ahead.
the only time I take supplements for those out there is when my doctor or my dietitian says I need something. And those supplements are things like they're saying, James, eat more fiber. I can't. I'm not getting enough of it. And for a short time, I took a fiber supplement just to help get me to where I needed to be. Um, Please, everyone, the supplements that are out there, the herbal supplements, there is no evidence for those. And there are people out there selling them to us, taking advantage of our desire for a magic pill just to get money from our wallets. And as Dr. Rose said, they're not regulated. You could do some research. Some of them have like sawdust as filler in them. You never know what's in there, and some of them are dangerous. So when it comes to any kind of supplement, something you're going to take besides medication or real food, only take what your doctor tells you need. And if somebody else is taking something, that doesn't mean you need it. So
Yeah.
the
I
advice
don't.
only comes from your doctor.
I'm with you on fiber. I think fiber is great. I think we need to get more plant-based, fruit-based diets, which have fiber in it. Fiber is good for your gut. Fiber is good for your blood pressure. Fiber is good for your sugar control. Fiber is good for decrease your cardiovascular, your heart risk. So fiber is definitely good if you want to consider fiber a supplement. That drug, by the way, is finerenone. It is a very expensive aldosterone antagonist, the third type of drug. Remember, we mentioned ACEs or ARBs, use one or the other, and SGLT2, there's 5 different types of those. And then you've got the aldosterone antagonist. The finerenone is ridiculously expensive, and I would opt if you're going to use the 3 drugs. And again, the first one is an ACE or an ARB, and the second one is an SGLT2. And if you still got significant protein in the urine, you can add an aldosterone antagonist. I would add spironolactone or eplerenone. These are much cheaper, and they'll do the trick. That drug is extremely expensive. Corendia is finerenone. Okay. Um, uh, okay, some of these are not really. Yeah. So, yeah, Dawn is asking about dietary protein and how that affects urine protein. And that's not the way to treat the protein leak that people get with kidney damage. With kidney damage, the cells in your kidney just leak this protein, this albumin, gets into the urine, and it really doesn't. Now there is basically some population-based data that shows that meat-eating people have higher risk of getting kidney disease. But that has nothing to do with the protein in the urine, to my knowledge. Plant-based diets will decrease your risk, theoretically, of getting kidney disease. But more importantly, as we mentioned, if you've got kidney disease, 5 out of 100 of you may have to face dialysis, but the other 95 of you need to worry about the heart attacks, the strokes, and stuff like that. And exercise and plant-based diet are important components of decreasing the risk of what you really need to be worried about, much more so than going on dialysis.
I got a great question here. Happy Girl asks, can any doctor check for protein in your urine?
Oh yeah, of course, yeah. I mean, basically, it's a lab test. I mean, there's a dipstick, which is a screen, which I'm fine with. If your dipstick is consistently showing 1 or 2+ each time, you may have significant protein in the urine. But getting that albumin to creatinine ratio, every lab should be doing it, and that's what you should be following. Um, Somebody's looking at reversing from stage 4 to stage 2 keto. I do not recommend ketogenic diet. It is one of the dangers of the SGLT2 is ketosis, which is like a starvation kind of problem where you get acids building up. I'm totally against ketogenic diets. They have no place for anybody with kidney disease. Absolutely not. I would stick with plant-based diets. Somebody said, please answer my question. I've been trying to get an answer for months.
Oh,
Anyway.
you did. It was about the supplements.
Okay. All right. Somebody says, I get a cystitis C. No. So Forks brings up cystatin C. Okay. So let me just review real quickly. The creatinine in your blood is just a marker that we use to measure kidney function. Not cystitis, but cystatin is another thing in your blood that we can use to measure kidney function. What is the main aspect of the human body that will give you a false estimated kidney function number? What particular aspect of your body?
Is that muscle mass?
Yes, absolutely, James. Right on. So because that your muscle mass is the primary determinant of how much creatinine you're going to have in your body. Again, the creatinine is just a marker that we use to measure your kidney number. There is another marker called cystatin C, and that's less influenced by how much muscle you got in your body. And so if there's a question about whether you're getting an accurate kidney function number, you have a choice. You can actually get your doctor to give you a jug to collect 24-hour urine, which is not done very often because it's inconvenient, or you can get a combined creatinine-based GFR and a cystatin C-based GFR. So Monita, the albumin 3.6 protein and albumin globulin. Yeah, so none of these are really pertinent and to kidney disease right there. It's put me into Medicare. Hold on. Yeah, so Jardiance is what's Jardiance? Is that an SGLT2? I think it is.
I think it is.
Yeah. Listen, I know, and I feel for all of you folks who are trying to get the, no, sorry, that's not. That's the GLP-1. Okay. But let me, before I go into Jardiance, which is a GLP-1, the weight loss drug, semaglutide, okay,
Right.
which is about $1,000 a month. Okay. I'm going to get to that Jardiance in just a second. But what I'm talking to you folks about who got protein in the urine, that SGLT2, those are expensive too. I hope that there's gonna be more and more of them available. They will eventually be generic, and I just hope you can get those. They're important drugs. They not only decrease the protein in the urine, which can slow the decline of your kidney function, but they also have remarkable benefits to decrease the other thing you got to worry about. Remember, I said only 5 out of 100 of you in stage 3 may ever have to worry about a dialysis thing. 95% of you, the other 95 of you want to decrease your risk of dying from a heart attack or heart failure, and the SGLT2s will do that. So they are extremely important drugs. Now, that said, let me go on to the GLP-1, the weight loss miracle drugs. They are great drugs. So she is on this drug, this semaglutide, the weight loss drug, for the second year now. In the Medicare donut, all my meds cost more now. I sure hope the price comes down. I mean, the drug companies are making money hand over fist. And I don't know whether or not we're going to, there's supposedly legislation about negotiating Medicare prices for drugs. I don't know if it'll happen, but I think it is an important drug. I think it will benefit a lot of people, but I can't tell you when it's going to happen.
Well, and one option, I don't know about this one, but reaching out to whoever makes a drug and see if they have any programs to help reduce the cost. Oh, that's Eli Lilly. I don't know how good they are at having programs.
Yeah, I mean, these drugs they are ridiculously expensive, but they do work. And you know, if you can lose 10-20% of your weight, you certainly can have improvement in your blood pressure, your blood sugar, and it may even benefit your kidneys. But I realize it's a very expensive way to lose weight. Did we answer Sandra's question about no protein in the urine, eGFR 58, 70 years old? So I would say it's questionable whether you have CKD, right? And the names of the SGLT2, James will put them on the show notes.
Yeah, I'll add them to the description after we're done.
Yeah, they're not going to really mean anything unless you look at them and you know you can shop around and see which ones you can get for the best price. So here's Marco Polo. Should I get a biopsy done? I'm at stage 4. eGFR is 25. Is it safe? Will I lose more kidney function? Okay, kidney biopsy. When should somebody, should your doctor, should you consider a kidney biopsy? The main time to consider a kidney biopsy is if you've got a kidney problem that is undiagnosed, what the etiology is. The commonest cause, two commonest top causes are diabetes and blood pressure. That doesn't mean that that's the answer. And we don't biopsy patients that have a long history of high blood pressure or a long history of diabetes. We assume that that's the cause. But if you are one of these people that have other lab tests that indicate that you may have a systemic disease, like things called lupus, or things that are called idiopathic, meaning there's a whole bunch of glomerular diseases. These are diseases that cause you to spill protein in the urine, that the only way we can name them is when we biopsy them. And they don't account for a lot of people that wind up on dialysis. They may account for like 10% or less. But if your doctor is got a question about what the cause of your kidney problem is, the biopsy may help, because and before I would let any doctor do a biopsy or start dialysis, you need to ask them, you know, what are we going to get out of it? What's going to be the benefit? And going back to dialysis, if I could be managed medically, why put me on a machine, doc? If you can control my kidney issues, why put me on a machine? The thing about a biopsy, well, doc, what are you going to do differently if you biopsy me? And that's what I would ask my doctor. Is there a possible change in the medicines that you're going to use and so forth? But generally, when you get down to around 20, it's usually a little bit late to be doing a biopsy. Not unheard of, but it's usually done at higher levels of kidney function. So I'll leave it at that. Now, Ravindo, don't restrict protein. If you got protein in the urine, you can. Now, again, this is a transplant patient, so you have to ask your transplant doctor whether or not that protein in the urine can be addressed again with the ACE, the ARB, one or the other, SGLT2, one of those, and maybe a aldosterone antagonist. That's what I would consider.
Here's one from Rubber Wilbur I wanted to bring up here. He says, last year, the Journal of Clinical Endocrinology had a report showing that intermittent fasting over a 6-month time could improve renal function by activating lipolysis. Have you come across this study, is what he asked.
Well, I would forget the study. I mean, the study is not meaningful to me. But I will say this. There is probably a relationship between obesity and faster decline of kidney function. So, certainly it makes sense to be on a plant-based diet and to be on a relatively low protein diet, 60 to 80 grams. And if you can get the weight loss drug, if you are obese, that may actually provide you a benefit. Wow, okay, let's see.
We're almost at the top of the hour, Doc.
Okay. Let me just do Rory's. I've been given sodium bicarb, and at 10%. Look, so in addition to the drugs we've been mentioning today, especially if you've got protein in the urine, to slow decline of kidney function, there is a possibility that a simple thing like baking soda, sodium bicarbonate, may also slow decline. It's not going to hurt the decline. It may slow decline if you've got too much acid in the blood. And the way that would be diagnosed is the bicarbonate on your electrolytes. If that's running, let's say, in the 22 or less range, you should be on sodium bicarbonate. And generally speaking, as you get more advanced kidney disease, acids build up and sodium bicarbonate may well be necessary.
Yeah, for those that don't know, sodium bicarbonate is baking soda. They're the same thing. They come in pills or in a box.
Yeah. Dawn is on Verapamil. Dawn, I have nothing against Verapamil, but in general, for kidney patients, it's low on the list of drugs that I recommend. It's a drug that's good for people with a fast heart rate, with atrial fibrillation or atrial flutter, that kind of thing. But I'm going to have a whole discussion in the next couple of months on various blood pressure drugs and how they relate to you folks with kidney disease, because I think most of you are not on the drug that you really should be on.
Okay, how about one last one, Doc?
Okay, Sonam, brother is stage 5, and he's getting dialysis once a day. Is it good or enough? Sonam, my guess is if your brother is making significant amounts of urine, dialysis is not adding a thing to his, what we call endogenous, his own ability to have kidney function. The dialysis machine is not a great replacement for your kidneys. And once a day, if you've got a lot of urine that you're putting out and you're stage 5, but you're, let's say, 10 or 15 GFR, you don't need dialysis. Absolutely not. It's a waste of time and a waste of money. The time that you may well need dialysis is when your urine output is getting down below 500 and your eGFR is getting down below 5. Once a day is not doing anything.
All right. There.
Dawn says boo-boo costs too much.
It's so true. And it costs more than just money in your wallet. It could accelerate your declining kidney function. All right, Doc, this has been fantastic. We have so many comments, so many questions. You got to a lot of them. It was fantastic. Dr. Rowe is here every month. He usually has a topic he talks about, and then he always makes time to get to some questions. So this is great to have a full hour going over questions. Thank you so much, Doc, for your time. And we had quite a few challenges. Doc was without power for a long time. It just came on like 3 hours ago, or not even that long ago.
Yeah, it's crazy times.
And then there were other issues, technical issues. We were trying to connect right before the call, but we made it through it all. We're so happy that all of you were able to join us tonight. Again, I want to mention his book. The book is called Learn the Facts About Kidney Disease. You heard the doc here firsthand. He talks in a way that you can understand, and this book is written so that you can understand it. That's probably the first takeaway I had for this book was, holy cow, I understood the entire book. Plus, it makes it so easy to know what you need to focus on, what matters, what doesn't, and it takes away so many of the things that us kidney patients worry, especially after we've been diagnosed and we're going through that process of learning about kidney disease. And you can get his book on Amazon. There's also a link, go.dadvicetv.com/book. That'll take you right to it on Amazon if you want to get yourself a copy of it. It's a fantastic book. All right. I'm going to sign us off here. Thanks again, Doc. Thanks, everybody out there. I do have another video next week. A new renal dietitian will be on to answer questions and talk about stuff. I can't remember what the topic was, but I'll be posting it real soon to Facebook and to YouTube so you guys can know. I think it's next Thursday we're doing it. But otherwise, I will see all of you in the next video. Bye, everyone.